important structures, anatomical structures plays a major role while placing corticobasal implants. So this is the nasal floor, nasal aperture. This is the nasal floor. We have to perforate the nasal floor while placing these implants in the anterior maxilla. Your implants will come through the nasal aperture. That is the nasal spine. This is the nasal spine area. Okay, you have to perforate the nasal floor here. Can you see? Usually the implants in the X-ray will be visible here. This is perforating the nasal floor. You have to place a corticobasal implant. If you can engage your implant through the nasal spine, so the stability will be good. So this is the nasal spine area where we have to perforate and place a corticobasal implant. So while placing the zygomatic implants, the anatomical structures of importance is infraorbital foramen. This is the infraorbital foramen. Usually the zygomatic implants will be placed angulated, usually from the first premolar the second premolar area, angulated towards the buttress. This is the buttress of the zygomatic bone. Can you see? We place sometimes quad zygoma, means 2 zygoma on this side, 2 zygoma on that side, and sometimes triple zygoma, that is 3 zygomas also placed in the zygomatic implants. So if there is need of more stabilization, so this is the zygomatic buttress. This is the zygomatic buttress. So apart from that, you can go back to the pterygoid area. So I'll just briefly explain about the pterygoid implants. This is the lateral pterygoid plate, and this is the medial pterygoid plate, and this is the hemular notch. Okay, can you see? This is the hemular notch, and there is a greater palatine foramen on both the sides. So this is the maxillary tuberosity. So here in the pterygoid plates, we have to engage the implant. We have to engage the implant in the area between the lateral pterygoid and the medial pterygoid. That is area between the lateral and the medial pterygoid. That we call it as a pterygopalatine fissure. There is a pterygomaxillary fissure. In that fissure, we have to engage the implant in this direction. Okay, it has to be this way, medially. It's almost in angulation with the hemular notch. So that is the bone, the column of bone where the hemular notch passes. That through that column, you have to place the implant here. So direction is towards the medial pterygoid plate, away from the lateral pterygoid. You have to be careful about the lateral pterygoid. So the lateral pterygoid will have 2 heads. One is the superior head and the the superior as well as the deeper head. So here the main problem is the traversing of internal maxillary artery. So internal maxillary artery, which is a branch of a carotid artery, so it passes in the deep muscle area of pterygomaxillary fissure. Here you have to be careful. Your implant length should be not more than 28 or 30 mm. Sometimes, usually the internal carotid artery lies around 40 mm above, means from the tuberosity. So you have to be careful not to do osteotomy towards the lateral pterygoid plate. Okay, so when there is atrophy of the maxillary tuberosity, usually when there is atrophy of the maxillary tuberosity, usually your osteotomy should be from the distal root of the second molar, angulated medially along the line of hemular notch. Okay, when the tuberosity is good, when you have the bulk of tuberosity is there, so you can start from the buccal aspect of the tuberosity, angulated 15 to 20 degrees medially and distally, and you can go through the you can proceed with the osteotomy. So here in the pterygoid implant placement, it's a blind technique. Why I call blind technique is because nobody perfectly knows where exactly is the fusion zone. The fusion zone is the area where you are going to engage your implant. The fusion zone is the area where you are going to engage the implant, that is between the medial and the lateral pterygoid. This fusion zone, usually you have to locate this mineralized bone through tactile approach. Tactile approach means, so you have to start the osteotomy, feel the bone with any kind of pathfinder instrument, then proceed another further for the osteotomy. You have to engage the implant in the area, that is the fusion zone area between the lateral and the medial pterygoid. So you can place two implants in the pterygoid region, that is the distal implant should be lengthier when compared to the mesial implant. You can place the double implants on both the sides, engaging through the tuberosity. Sometimes we call it as tuberopterygoid implants. Sometimes we place the implant traversing the posterior wall of the maxillary sinus also. So there are three different steps are there in this one. We place the implant in the pterygoid area because if you can, in full mouth cases, if you can engage the implants in the pterygoid plates, you get maximum stability for the whole framework. So there won't be any cantilever effect, and your processes will have good retention and stability also. So in the full mouth cases, the anterior nasal sparing engagement as well as in the posterior pterygoid engagement, and also in the canine bypass also we can do. Usually from canine to canine we place 6 implants, and both the pterygoids we place a double pterygoids. So totally 10 implants we place it in the maxilla, that is in full mouth cases. When come to the mandible, I'll have a brief explanation about the mandible also. You can have a look at the this is the mental foramen. This is the mental foramen. You can have a look. It lies just below the second premolar or little mesial to the second premolar. Here on the both the sides will be the same. This area have to be careful while placing the implant. The inferior alveolar nerve or inferior alveolar bundle, which passes in between this labial as well as the lingual plates. So usually in the second molar and the third molar and the second molar area, the bundle will pass towards the lingual, and in the first molar area it runs towards buccally. So that's the way it runs. That is the inferior alveolar nerve. It passes through and exits to this canal, that is the mental through this foramen, that is the mental foramen, and it sometimes it gives branches from here also into the muzzle. So this is the same thing on both the sides. So there is a mental foramen on both the sides. While engaging the implant in the anterior mandible, it's very easy. There won't be any important anatomical structures. You can engage till the base of the mandible. You can engage up to 20 mm or 21 mm. Only thing is you should not perforate the lingual aspect of this mandible, where there will be lingual plexus of arteries, small capillaries. If you're going to perforate the lingual plate, there will be anastomosis. These arteries will bleed, and you may come across hematoma in the floor of the mouth. That should be taken care of. And while placing the implant in the molar area, if there is atrophy is there, you have to angulate the implant. How we are going to angulate the implant? You have to angulate from buccal to lingual. That we call it as nerve bypass technique. So we are going to engage the implant in the mylohyoid ridge, mylohyoid bone. So we are going to engage the implant in the inferior quarter of the mylohyoid bone, that is the D2 bone. So and then you can bend the implant for the occlusion. That can be done on both the sides. So this is the way you are going to place the implant in the maxilla and mandible in the full mouth cases. Thank you.